Morning, everybody. Eric Chaconis here for PT on Ice. Today, we're going to talk about kind of what to do when you're in a situation where you're trying to integrate exercises, you're trying to progress your loading program for an individual, but they just don't tolerate the interventions well. So there's a lot of situations when this occurs, right? People can be just in that stage of healing where they really can't tolerate a lot of stress through the shoulder joint. The tissues just aren't ready. They need to heal a little bit more. High irritability is a common one, right? Person comes in with high pain levels, doesn't tolerate a whole lot. Very easy to flare that patient up. And you got to have a little more finesse and kind of back things down a little bit. That's a pretty common thing. And we certainly see this a ton in post-operative rehab, right? If we are in a situation where we're week 4 post-operative rotator cuff repair, for example, or labrum repair, any type of surgery where we have to let those tissues heal a little bit more. We can't put too much stress through the shoulder joint. We're going to want to come up with some alternative interventions. There's some other things that we're going to want to do and focus on in that time. And so this is a problem that I think people mention as sort of a common kind of issue. What do I do in these early phases when I can't do a whole lot for the shoulder? And in my experience historically, what I kind of did early in my career was really take a more passive approach. So I would default to, modalities or passive manual techniques and stuff like that. And I think that in some situations, that may not be the ideal choice. I might want to take a more active approach. And so that's what I'll talk about today. And certainly when we have these central processes, these psychological processes, the active approach is going to have some merit. So one great little technique you can utilize is simply train the contralateral limb. And I know I've talked about that in the past. We covered that in knee one time, but on one of these PT on Ices. But it's a pretty well documented, technique that if I train the uninvolved limb, so in this case, maybe we're providing rehabilitation to the left shoulder. It's left shoulder pain, left shoulder injury. We're simply going to perform exercises on the opposite side and get this crossover effect. So that's a phenomenon of the nervous system where we get this crossover effect, and the untrained limb, the limb that we are not even exercising, is going to actually benefit and have a strength increase. Now you'll see that kind of close to 12% contralateral increase in strength is across the board. That's an average. You'll see that actually a little higher for the lower limb than the upper limb. And then also the type of contraction, the type of exercise that you utilize will make a difference. So it seems like the slightly heavier load, isotonic and eccentric movements may provide more benefit. So I really like this a lot because they will then learn whatever exercise we're going to integrate for the involved limb eventually. They can learn that exercise before with the uninvolved limb, and then obviously you get that contralateral carryover, which is really nice. The other idea is can't really target the shoulder. The shoulder won't tolerate a whole lot. So I'm just going to focus on this idea of total arm strength. The idea of let me work distal. And if the entire arm, the entire limb gets stronger, the patient's going to have a lot of benefit from that. So there's this idea that when I have shoulder pain, not only does my shoulder get weak, not only do I get arthrogenic inhibition and muscular inhibition around the shoulder, but the entire limb is actually going to be impaired as well. And so working the biceps, working the triceps with different angles, different movements, just to the patient's tolerance, I kind of want to fly sort of below that pain radar, not flare them up, but still get some strengthening going, and I can do that distally. Going all the way distal is another really nice one because we know there is an association between grip strength deficits, fine motor skill deficits, and shoulder pain. And so when you see weakness in the rotator cuff, there's oftentimes also weakness distally. And so grip strength can be an issue. And this is a great intervention early on when the shoulder exercise isn't tolerated to just focus on simple grip strengthening type movements. I like to integrate, and actually here, we've talked about this before on the show, loaded carries. So if I can do a loaded carry now, I'm moving, it's dynamic, and not only am I loading for their grip strength, but also the shoulder girdle as well. And that oftentimes can be pretty well tolerated because I've got the shoulder in a fairly benign or position that's not going to flare them up. Specific grip movements too, like this pinch grip training where he's got to drag these pennies out of, you know, the putty, and that's just a nice specific pinch grip training instead of whole grip training for the entire hand. I can work specific fingers and work fine motor skills as well. And then going proximal, and this is something that, you know, we talk about a lot, is the idea of manual therapy to the thorax, spinal manipulation, rib manipulation in patients presenting with shoulder pain, and how that gives you that regional hypoalgesic effect. You're going to get a pain reduction early on. There's a whole host of things I can do to the scapula, from a rhythmic stabilization, isometric and isotonic strengthening, while the shoulder's in that very safe, comfortable, protected position and not really going to put a lot of stress through the shoulder joint itself, but I can still train the periscapular musculature in that situation. It's pretty well documented that thoracic manual therapy has a beneficial effect on shoulder pain, even up to 1 year post-treatment, when you compare it to sort of standard of care interventions or education and rest. And so I think, you know, that's still, you could say, well, there's not a causal effect. It could be the fact that we're just touching them. It could be the fact that we're providing, you know, some type of other non-specific effect to the shoulder girdle or to the person. And that's true. I'm not saying that thoracic manual therapy is the only thing that you should do or the main thing that you should do. I think whatever works well for you, that you get that sort of immediate, early, within session change, and that you get some carryover between visit 1 and visit 2 and pain reduction. It could be a number of things. It could be, you know, taping. It could be soft tissue work. It could be whatever it is that you know, appreciate or think that will be beneficial from a passive manual therapy perspective or passive perspective. I think there's some benefit there. The bottom line is this: I really want to achieve early, within session change. So on visit 1, if that patient comes in with a pain level of, let's say, 6 out of 10, I really want them to leave at a 4 out of 10 or better. So I like to try to achieve that kind of MCID for pain scores early, visit 1, visit 2. That's going to give the patient more confidence. It shows them, gives them proof, oh, this person's actually able to help me. I feel an immediate reduction in my symptoms. I think that builds trust and potentially carry over for patient expectations. If you look at Rachel Chester's work, she looked at all these different variables that influence outcome in people with shoulder pain. And the one variable that seemed to hold up above all else was the patient's expectation for a full recovery. When a patient said early on, I expect to get better, I expect to completely recover after seeing this physical therapist or after going through this rehabilitation process, that seemed to be the variable that mattered the most. So I think anything you can do to improve patient expectations early on, improve their confidence and trust in that, you know, this experience with you is going to be one that's going to help them, you know, that's going to give you pretty good carryover. And so what we want to see is early reduction, and then we want to see that reduction carry over to visit 2. Visit 1 and visit 2 are so critically important. If you can make big changes in visit 1 and visit 2, that kind of sets you up for success throughout the rest of the course of rehab. So just a little plug there for this early reduction in symptoms. However you can achieve that is a goal. All righty. Thank you guys so much. I don't have any more extremity management courses in 2018. We're going to start kind of setting a few up for 2019. I'm going to try to get out in kind of every quarter of 2019, get to a different part of the country. So if you're interested, let us know, message me on Facebook, and we can set you up if you want to host the course. And I hope to see you soon. Take care, everybody.